Hello, everybody. Welcome to our talk, Sleepless in CL, an integrative approach to treating insomnia in the consultation-liaison setting. I am joined by Dr. Yoel Green, Dr. Bernice Yao, and Dr. Michael Mack, and my name is Yaakov Green. So our journey will include 4 parts. Part 1, we have a neurobiology primer, where we will review the neurobiology of sleep. In Part 2, we will be discussing an approach to assessing and treating insomnia in the hospital setting. In Part 3, we will discuss a case that highlights this approach. And in Part 4, we will hear from a sleep expert on recognizing other sleep-wake disorders, as well as advanced sleep testing. Our learning objectives are as follows. Number 1, to identify fundamental sleep-wake neurocircuitry, including the reticular activating system, the ventrolateral preoptic nucleus of the hypothalamus, circadian rhythm, sleep-wake homeostasis, and orexin. Number 2, to apply an integrative approach to treating insomnia in typical CL cases, including current guidelines. And number 3, to name other sleep-wake disorders, recognize their core symptoms, and identify when to pursue specialized consultation. So let's begin our neurobiology primer. And in this part, we will walk through history and build a model of sleep-wake neurocircuitry one piece at a time. This is based on an article that I co-authored with Drs. Green and Yao in collaboration with our mentor, Dr. David Ross. I want to start here with this gentleman. In the 17th century in England, Dr. Tobias Venner was a physician, and he was seeing numerous patients who presented to him with a similar complaint. They were all struggling to fall asleep. And what he found at the time was that people were prolonging their periods of wakefulness at night by reading by the candlelight. And he was perplexed by this, and he was disturbed, and he tried all sorts of remedies. And one thing that he proposed was a nightcap, a mixture of almond milk, barley, violets, and rose water. Some of his contemporaries suggested that patients tie vinegar-steeped pieces of bread to their feet. And these might seem like strange remedies for insomnia, but they all came from the idea at the time, the belief that sleep arose from vapors that would rise from the gut during digestion. Fast forward to the 19th century, and it became widely understood that the brain was the center of consciousness. This is the time of Broca's aphasia and Brodmann's areas. And this led to the understanding that whatever was happening during sleep was happening in the brain, and in particular, the cerebral cortex. And this is the first piece of the puzzle. In the next century, the 20th century, a mysterious illness affected millions of people in the wake of the Spanish flu, and it was termed encephalitis lethargica. It had numerous symptoms, one of which was severe sleep disturbance. Austrian physician Konstantin von Economo was perplexed by this condition, and he conducted numerous thousands of brain autopsies on individuals who passed away from the condition. And what he found was lesions, common lesions, found in and around the hypothalamus. And thus, the next piece of the puzzle was uncovered. The hypothalamus, and in particular, our current, more recent research has revealed that the ventrolateral preoptic nucleus, in particular, in the hypothalamus, is a fundamental piece of sleep-wake neurocircuitry. GABA, and to some extent, galanin, projections from the VLPO throughout numerous regions in the brain are inhibitory and stimulate a state of sleep. So this is the first pillar of sleep-wake neurocircuitry, inducing the cerebral cortex into a state of sleep. Numerous agents are used on this system to induce sleep. GABA-A agonists, such as alcohol and benzodiazepines, and barbiturates, as well as newer Z drugs, all operate by agonizing this pathway. The next key discovery occurred in the 1930s. This was soon after the EEG was invented, and it was applied to numerous scientific studies. One of the things that scientists quickly jumped to study using the EEG was sleep. They wondered what happened in the brain while people sleep. And they expected the brain to be kind of in a pattern of inactivity, but what they found was the opposite. The brain was highly active. And we could see here some EEG readings of the brain in a state of sleep, and we see that there is electrical activity and the brain is active. So sleep is active. And the second thing they discovered is that sleep is dynamic. Not only are there brain waves, but there are predictable patterns of brain waves that occur in different phases throughout sleep. Our current nomenclature for these include the 4 stages, REM, rapid eye movement sleep, as well as non-REM stages of sleep, such as N1, N2, and N3. They all have unique brain patterns, and they serve unique functions. The next discovery occurred in that same century using the same technology by a pair of scientists, Maruzzi and Magoon. In their experiments, they had a cat, they sedated the cat, and they connected the cat's head to EEG. And they probed and stimulated different regions of the brain to see what would happen. And as they simulated one particular region of the brainstem, they found that the entire cortex lit up into a state of wakefulness. And this region became known as the reticular activating system. It's a collection of numerous projections and their nuclei, mostly monoaminergic, that simulate a state of arousal throughout the brain. So here comes the second pillar of sleep-wake neurocircuitry, the reticular activating system. We see here that norepinephrine, serotonin, dopamine, histamine, and acetylcholine are all involved in this network. Many agonists, such as drugs of recreational drugs like cocaine and crystal meth, as well as prescription stimulants, and even some SSRIs create insomnia or activation by agonizing the reticular activating system. Other drugs like opioids have mixed effects on the reticular activating system. And lastly, numerous antagonists are used as sleep aids, including antidepressants such as doxepin and trazodone and mirtazapine, second-generation antipsychotics, gabapentin, and antihistamines. So here are these 2 fundamental pillars, the VLPO and the RAS. Interestingly, there is a unique feature. They antagonize one another to create a flip-flop switch, meaning that as one is active, the other is off. So the brain is either in a state of full sleep or wakefulness. When this flip-flop switch is dysfunctional, that could give rise, it is theorized, to parasomnias, which are characterized by a state of neither full sleep nor wakefulness, a sort of mixed in-between state. So we have our 2 fundamental pillars, but how does the brain know when to switch into a state of sleep or wakefulness? Well, there are 3 regulatory mechanisms. The first one is called sleep-wake homeostasis. The idea here is that during a period of prolonged activity, the molecule adenosine accumulates in the brain and stimulates a state of wakefulness by acting on this circuitry. A famous antagonist of adenosine is caffeine, and it prolongs periods of wakefulness by inhibiting this regulator. The next fundamental regulator is the circadian rhythm. Melatonin rises and falls in a 24-hour cycle that stimulates the brain into a state of arousal or sleep, depending on the time of day. It syncs it to 24-hour cycle. And the mechanism here is that light reaching the retina in the back of the eye triggers the suprachiasmatic nucleus to inhibit the pineal gland from releasing melatonin. And there are numerous things that can modulate the circadian rhythm. We think about melatonin and melatonin receptor agonists like Ramelteon, as well as other non-medication interventions like light boxes. Things such as food and social activity and exercise also entrain the circadian rhythm and can be used to our advantage when thinking about how to help our patients regulate their sleep schedules. The last regulatory mechanism I will highlight here is the neuropeptide orexin. And it functions to stabilize the awake state by stabilizing and supporting monoaminergic tone in the reticular activating system. A deficit of orexin is implicated in the disorder of narcolepsy, which is characterized by an unstable state of wakefulness, where patients easily fall asleep. This pathway could be used to our advantage with certain medications. One very new class of sleep aids are the dual orexin receptor antagonists, namely suvorexant, lemborexant, and daridorexant. These antagonize the orexin receptor to destabilize the awake state. On the flip side, some agonists are under development to treat narcolepsy. So here we have the fundamental sleep-wake neurocircuitry. It is composed of the two fundamental pillars: reticular activating system, stimulating wakefulness, the VLPO of the hypothalamus, stimulating sleep, the flip-flop switch between them, and these three fundamental regulators: sleep-wake homeostasis, circadian rhythm, and orexin, helping the brain know when to enter a state of sleep or wakefulness. And given the complexity of this neurocircuitry and the numerous components, it is no surprise why so many things could disrupt sleep. Sleep is such a delicate balance. There are numerous drugs highlighted here in orange. We're not going to go through them in detail right now, as well as nearly all psychiatric disorders that impact sleep by acting at different points of the circadian rhythm. Now I will hand it over to Dr. Yoel Green for his discussion of an approach to assessing and treating insomnia in the CL setting.
Hi, my name is Dr. Yoel Green, and in part 2 of this presentation, I'm going to be discussing an approach to assessing and treating insomnia in the CL setting. For context, insomnia is the most common sleep disorder. It's prevalent in about 30% of the general population with a sleep complaint, and 10% of the general population will meet the DSM criteria for insomnia. Within the hospital, new onset insomnia can be found in approximately 35% of patients. And so treating insomnia in the hospital is very important because it's not just about quality of life, but it's about adverse outcomes that can come from it, including the risk of development into chronic insomnia, the risk of exacerbated mental health. We know it's a risk factor for delirium, and then also impaired illness recovery through dysfunction of various systems, such as the endocrinological system, circadian system, and through altered cellular immunity. From a diagnostic perspective, insomnia can be thought of by a sleep complaint, where an individual will have difficulty initiating sleep, maintaining sleep, or waking up too early. And this is associated with frequency and duration criteria, where an individual will have difficulty for at least 3 nights per week for at least 3 months. In the hospital setting, we're going to be focusing on the sleep complaints and how we can address them. So how does insomnia develop? One useful approach is an approach that's very common and well known within psychiatry, and that's considering predisposing, precipitating, and perpetuating factors from a biological, psychological, and social perspective, considering the neurobiology and also things like classical conditioning. Taking a deeper look at this, thinking about within the hospital setting, insomnia can be predisposed by mental and medical comorbidities, by psychologically through a person's stress reactivity, their sense of safety within the hospital, or social factors such as being female or in certain minority groups. The hospital can represent various precipitating factors to insomnia, including acute illnesses with associated pain, anxiety, or maybe withdrawal from substances, the inherent social disruption in hospital admissions, and then environmental factors in the hospital like light and noise. Specifically to the hospital, and also commonly, there are various perpetuating factors that we know can lead to insomnia developing, including untreated mental health and physical health conditions. And these can lead to learned negative sleep behaviors, such as sleeping and napping inappropriately. And through classical conditioning, through rumination and anxiety about sleep, the bed can become a conditioned stimulus for wakefulness as opposed to a stimulus for sleep, which may in turn lead to hyperarousal both physically and mentally, which all may perpetuate insomnia in the hospital. And because it's so multifactorial, assessing and treating insomnia requires an integrative and multimodal approach. We'll start with a comprehensive evaluation, which includes not just the nighttime history, but a 24-hour history of both sleep at night and daytime behaviors that can be contributory to sleep. We also want to consider a patient's psychiatric history, their medical history and physical, a review of the medications, and then collateral from those close to the patient, such as nurses, family, or even nursing logs. This can all be integrated into a biopsychosocial formulation that we've recently spoken about. After we formulate the patient and we understand what's going on, educating the patient and the team can be very impactful. We want to discuss these predisposing, precipitating, and perpetuating factors with the patient and the healthcare team, and then discuss what our goals are, both our primary goals, which might be to reduce onset of sleep or to minimize awakenings after sleep onset, but also the secondary goals of improving our patient's health and their outcomes. And because insomnia is often secondary to other conditions, we want to optimize these very comorbidities, including mental disorders and optimizing the medications that we use to treat them. And insomnia is often secondary to medical conditions, like I've alluded to, across various systems, including our musculoskeletal system, including pain, our gastrointestinal system, such as GERD, or even our genitourinary system, including symptoms like nocturia, and more. And so when it comes to treatment, the strongest evidence base is for a treatment called CBTI, that stands for Cognitive Behavioral Therapy for Insomnia. And CBTI is a short-term information and skills-based therapy, including 5 modules that are extremely helpful for treating insomnia. It includes sleep hygiene, which are the healthy sleep behaviors that many people try to optimize sleep, including optimizing the bedroom environment, minimizing caffeine. It also commonly includes things like relaxation or cognitive approaches, but there are 2 main approaches that are most helpful and most evidence-based in CBT for insomnia, and that is stimulus control and sleep restriction. When we think about these 2 approaches, stimulus control is an approach where we want to reassociate the bed with sleep and sleep alone and reduce the association between the bed and wakefulness. So reassociate the bed with sleep. And sleep restriction is basically mapping our sleep need with our sleep opportunity versus various skills. And this is reflected in the American Academy of Sleep Medicine clinical practice guidelines for chronic insomnia, where there's a very strong recommendation for multi-component cognitive behavioral therapy and a conditional recommendation for stimulus control alone and also sleep restriction alone. And these 2 factors and modules can be modified for the hospital environment. So thinking about sleep restriction, one good way to help our patients optimize their sleep need with their sleep opportunity is to ask them, well, how much sleep do you usually need at home? And when they tell you that, that can help you identify the optimal sleep parameters for our patients and help make them regular through minimizing napping, setting realistic goals, trying to bundle the clinical care so that the number of patient interactions is minimized to disrupt sleep, and also reconsider the necessity of the vital sign frequency. And then stimulus control is extremely effective. And we know this can be hard to address in the hospital. The common aspect of stimulus control and associating the bed with sleep and not wake is the advice that if a patient is not sleeping, that they get out of bed. This could be modified to the hospital environment, where we could tell a patient, well, if it's taking you more than 15 minutes to fall asleep, you may sit up in bed to help break that association between the bed and wakefulness. We also want to recommend that the patient, if possible, avoid napping, avoid eating in bed, minimize computer use in bed, clock watching, or even phone calls. Circadian approaches can also be modified to the CL setting. And we think about in training our circadian rhythms to optimize our 24-hour cycles within the hospital. And there are various ways that we could do this, including opening window shades during the day, having dim lighting in the rooms prior to wind down, orienting the patients, avoiding skipping meals, which helps entrain our circadian rhythms, being thoughtful about activity scheduling and considering the use of melatonin. Our guidelines also acknowledge that when psychological and behavioral interventions are ineffective or incompletely effective, there is also an important role for pharmacotherapy. And when we think about the approved medications for insomnia, they tend to act on 4 neurochemicals, neurotransmitters, including orexin, melatonin, histamine, and GABA. And so how do we pick? And how do we pick between these pharmacological agents? Well, there are various factors that are important to consider, including what is the symptom pattern? Is the sleep complaint a sleep onset or sleep maintenance concern? What is our treatment goal? What are the pharmacokinetics of the medication I'm using? What's the half-life? Does this medication interact with other medications that the patient is on? It's also important to consider other unique patient characteristics such as age and apply helpful criteria such as the Beers criteria for safe prescribing in the elderly. And also we want to consider their mental health comorbidities. General safe practices include using the lowest effective dose, optimizing the timing of the medications, avoiding co-administration with other sedating medications, and then discussing the risks such as daytime impairment, tolerance, and rebound insomnia. And so when it comes to the American Academy of Sleep Medicine, they do have guidelines for what medications to use when we're treating chronic insomnia. And we often look at these when we're also treating acute insomnia. And these include medications from across those classes, like I mentioned, such as suvorexant, which is a dual orexin receptor antagonist. We have certain Z drugs there. We have sedating antidepressants such as doxepin, and melatonin receptor agonists such as ramelteon. And we could see that their indications are either for maintenance or onset insomnia or both. They also specified that there are recommendations not to use various medications, including trazodone, which is one of the most commonly prescribed medications for sleep. And this is based off of the absence of demonstrated evidence for efficacy. And also there is limited evidence that there are harms and side effects that people experience, such as headache and somnolence, with the harms potentially outweighing the benefits. Similarly for diphenhydramine, absence of clear benefit, and melatonin as well, specifically for insomnia, due to the lack of evidence for insomnia in particular. And the guidelines also also mention that there are no recommendations for commonly prescribed gabapentin, quetiapine due to insufficient evidence, although we know these may be prescribed for comorbid conditions to harness their side effect profiles. And there's also no mention of mirtazapine or hydroxyzine. And so what's an approach to off-label prescribing? Like I mentioned, we want to consider comorbid indications and harness the side effect profile. You could see on the right-hand side that various antidepressants, antipsychotics, anticonvulsants, and other medications have sedating properties. And so when we're treating other conditions, we want to consider how we could harness the side effect profile of medications from within those classes. We want to consider the safety profile of the medications in insomnia, the efficacy, the American Academy of Sleep Medicine guidelines, and the general state of the knowledge using a very common sense and practical approach. One helpful thing to consider is the pharmacokinetics of the medications, including the half-life. And we see the circled medications here are evidence-based according to the American Academy of Sleep Medicine for the treatment of insomnia. And we can look at their half-lives and notice that often that their half-lives are very, very tightly correlated to the recommendation. So if we're treating initial insomnia or maintenance insomnia, we want to understand how we should consider the medication's half-life. And when it comes to the dual orexin receptor antagonists, there are several that are available to us, including daridorexant, levorexant, and suvorexant. And you could also see that they also have varying half-lives. So if you try one medication and benefit, and there might be there could be differences in their benefit, we also could consider other medications from within that same class. So I will now hand it over to Dr. Bernice Yao to apply this framework that we've just reviewed to a clinical case.
All right, so we're going to apply this framework to a case. The case that we're going to share is actually a truncated version of a case that's published in the JACLP under the case conference section. I would highly recommend taking a look at that for further details and further explanations. It's quite useful. So in brief, this is a case about a 67-year-old gentleman. He's got a history of MDD, panic disorder, treatment refractory hypertension, hyperlipidemia, BPH, and environmental allergies. And he's admitted to the hospital after an unwitnessed fall. He was found at home. He was unconscious. He was found by his children and therefore brought to the hospital for further evaluation. So we have put the framework that Yoel talked about at the bottom of the screen. So as we go through each section of the case, I'll highlight some of the elements that we use to treat this case and evaluate this case. So first things first, we want to make sure that we do a really thorough evaluation of this patient. So the first thing is, taking a look at his physical exam. So when you examine him, you notice that he's got some tenderness at the right occipital region, but fortunately no skin breakage. On a brief neurologic exam, his pupils are equal and reactive to light. There's no acute neurologic deficits per your exam, but you do notice that he's got some altered mental status. So he seems a little bit confused. He's oriented to his name and his age, but he doesn't really know the date or the day of the week. As a team, you do obtain some head imaging. So on CT scan, you notice that there's a small soft tissue hematoma that correlates to the area of tenderness. But fortunately, otherwise, there's no, intracranial bleed or no acute ischemia. So moving on, continuing with the evaluation, we review his outpatient meds. So he's on 2 psychotropic medications. He's on Lexapro 20 milligrams that he takes for depression. He's taken this for a long time. And he's also on clonazepam 0.25 milligrams twice a day, which he says helps with both his depression as well as his panic disorder. You review his other general medications as well. So he's on quite a few antihypertensives. He's on ramipril, hydrochlorothiazide, and amlodipine, and he's also taking some tamsulosin. And then he also uses diphenhydramine 25 milligrams as needed for allergies. So let's look at his hospital course. So he's first admitted to the medicine service. In addition to the physical exam and the head imaging and the medication review that you do, you also just order routine labs. Fortunately, his CBC, CMP all look okay. There's no signs of infection and no other kind of objective evidence of other things that might be causing his confusion. Because of that, you do decide that based on his medication review that you want to discontinue the clonazepam and the diphenhydramine. Looking at these medicines, these are the 2 that are probably going to be the highest culprits for causing confusion and causing falls. And fortunately, after discontinuing these, you notice that there's an improvement in his mental status within a couple days. As his mental status is improving, you get the opportunity to obtain further history from him as well as his family. He does share that the anniversary of his wife's death was actually approaching, and that's caused him to feel, much more depressed, and has kind of been ruminating about his grief quite a bit. When you do some depression screening, you note that his PHQ-9 is actually 14, and he does say that these feelings of depression and the grief are contributing to his difficulties with sleep. In addition to that, he does share that he also feels like he wakes up several times overnight to go to the bathroom. And oftentimes when he tries to go back to bed, when he tries to go back to sleep, it's really hard. And he'll actually take extra clonazepam pills to help him go back to sleep. So taking a pause there, there's already a ton of things that we can intervene on. So the first thing is that, we want to provide psychoeducation to both the patient as well as the family about potential side effects that their medications can cause. So notably, the Klonopin and the diphenhydramine are pretty high risk in this patient. So the team provides, counseling about the risks of these medications, and we make kind of a joint decision with the patient and their family to not restart these medications. In addition to this, it's really important to look at medical comorbidities as well. So one of the notable things was that part of his sleep disturbance is the nocturia that he's having. So there's a decision made to decrease the tamsulosin dose to see if we can decrease those nighttime disruptions. And then also, it's really important to think about the biopsychosocial formulation of the patient. So one of the notable things is that, his grief, the anniversary of his death, of his wife's death, is really contributing to some of the insomnia that he's having. So he's provided with some supportive psychotherapy while he's in-house, and then also given some psychotherapy as well as grief resources for the outpatient setting. And in addition to that, trying to regulate the circadian rhythm as much as we can in the hospital. So talking with the staff about minimizing nighttime interventions, consolidating labs and vitals to the daytime as much as possible, placing him in a room that's near a window. All of that will help a patient regulate his sleep-wake cycles a little bit better. So again, moving on to his hospital course. So fortunately, with all of these issues, his confusion has improved quite a bit, but he continues to have substantial insomnia. The hospital's formulary is unfortunately quite limited, but trazodone is started and it's up titrated to 100 milligrams at night, and this actually does help improve sleep, at least for the short term. Despite this, when you're talking with the staff on the unit, you get a little bit more information, and they said that he is sleeping better, but they noticed that he's been snoring quite a bit. And when you do a stop bang score, he actually scores 5 out of 8, which is concerning for moderate to severe OSA. So because of this, you do refer him to an outpatient sleep study to evaluate for obstructive sleep apnea. And fortunately, with all the changes that you've made, he's been improving quite a bit. He passes a falls assessment with PTOT, and he's ultimately discharged home. So looking at his outpatient course, he does present for a sleep study, which is concerning for moderate to severe OSA. He is started on a CPAP, and fortunately is compliant with it, and he has significant improvement in his insomnia and feelings of fatigue over the next 6 months. At his outpatient visit, though, his family does bring up the fact that there have been some near misses at home. They've noticed that there's been some near falls, especially overnight, and sometimes the patient's complaining that he feels dizzy when he gets up. And there's some concern that maybe there's some orthostatic hypotension, potentially from his antihypertensives, but also potentially from trazodone. And there's a decision made to switch the trazodone over to a safer medication, such as lemborexant. And ultimately, after a few months, the patient, kind of comes to you and says that he wants to really reduce the amount of sleep medicines that he's on. He doesn't want to take a sleep medicine for the rest of his life. And he wants to see if there's any other strategies that he can pursue in order to help with the sleep. You refer him to CBTI, and he completes the course with good effect, and he's ultimately able to be weaned off the lemborexant and does very well with just the CPAP. So I hope that's a very quick case, but hopefully that's, a quick illustration about how we can employ, a very thorough evaluation using a biopsychosocial formulation, and using these kind of 5 treatment strategies, including education, evaluating and assessing for comorbidities, using CBTI, regulating circadian rhythms, and also being very, kind of intentional about our pharmacology, both in terms of prescribing medications for sleep, but also peeling back on medications that might be causing problems. So we'll move on to our next section, and we're going to do a quick Q&A with a sleep expert, Dr. Mack, and we've got a few questions from general CL psychiatrists. All right. So as a general CL psychiatrist, I wanted to take this opportunity to ask Dr. Mack, who's our sleep expert, maybe some common questions that we have in our practice. One of the first questions that I had was that, it's really interesting to learn about the evidence for trazodone, because it is something that, we so commonly prescribe for sleep. So I'm curious, from your perspective, are there scenarios where we should use trazodone? And then what are some scenarios where we should not use it? And then a follow-up kind of question to that is, unfortunately, a lot of hospital formularies may be quite limited. So if we don't have access to dual orexin receptor antagonist or Vimelteon, how would you recommend approaching these cases?
Yeah, these are great questions, Bernice. And essentially, with trazodone, in terms of how it helps people with insomnia, it's only ever shown positive evidence if you take a person that has both depression and insomnia together. Outside of that context, there hasn't been any positive data that supports the use of trazodone as a routine treatment for insomnia. Moreover, there's been a number of studies now looking at very large population databases that implicate it as a main reason as why people will take a tumble and fall. So, given that we know that people who are older are at greater risk of insomnia and also delirium, this is some cause for concern. It's just something to keep in the back of your mind, recognizing that hospital formularies are very limited, as you say. We don't have access in most hospitals, most institutions, for safer medications. So what would be as a time to use trazodone for sleep, let's say inside the hospital? If you're dealing with a person that is not at risk or at low risk of having falls. So If you're dealing with a person that's mostly bedbound, this might be a medication to use. If it's a person that has a low risk of falling, there are good sides to trazodone. As an example, it doesn't come with anticholinergic burden. So if you're dealing with a person that, is at risk for delirium, if they have a background dementia, in that very specific situation, I think that it might be helpful. Now, in terms of DORA medications and Rameltian, these are on-label approved treatments for insomnia disorder. Rameltian is indicated for problems falling asleep. DORA medications en masse are indicated for helping insomnia both initially and in the middle of the night, meaning it helps you fall asleep and stay asleep. I think if I had a magic wand and we were able to add all these medications to the formulary, these would be the medications that we prefer. Last little bit about trazodone is that it's implicated as something that does prolong QT interval. So if we're dealing with people with bad sleep, they might have bad mood, and if they're taking citalopram or escitalopram, please do regular ECGs.
That's really helpful to know. And I think it's, it kind of changes our practice to not just reflexively prescribe trazodone whenever we hear insomnia, but really to think about, what are the comorbidities and kind of what are the risks, both from a fall standpoint as well as a cardiac standpoint for patients. Great. Our next question is, as CL psychiatrists, we're often not just consulted for cases of, solely a problem of insomnia. Oftentimes a common consult is, a patient is delirious, they get agitated overnight, they're not sleeping overnight. What are your thoughts about use of, low dose antipsychotics in these cases, especially for sleep?
Yeah, I don't see any issues with prescribing, let's say, low dose sedating antipsychotics, particularly if you're dealing with a patient that has delirium that's hyperactive. In a way, you're killing two birds with one stone. And, in that situation, medications such as quetiapine at low doses might be helpful. Some others might choose a very low dose of olanzapine as well. These are the more common sedating antipsychotics prescribed in this context. Obviously, you need to be careful about anticholinergic burden with some of these choices like olanzapine.
Thank you. And, another interesting thing about this case was, the focus on kind of optimizing non-psychotropic medications like the tamsulosin. And I think that's unfortunately something that we don't think about enough. I'm curious, aside from tamsulosin or antihypertensives, are there other, non-psychotropic medications that we should be thinking about and evaluating more often that can impact sleep?
Yeah, if you're dealing with a male patient, anything that modifies the treatment of benign prostatic hypertrophy is one. Diuretics that might increase the frequency of nocturia is another. This actually stimulates another point in mind, which is what about non-pharmacotherapy, non-pharmacological interventions? I think, to stabilize a person's sleep, you do well to do so without medications. And I think, it's something that we all know, which is, in a person that's at risk for delirium or if they have background dementia or a person with multiple medical comorbidities, do let them expose themselves to bright light, sunlight, preferably during the daytime, and encourage no naps during the day. And then making sure that, artificial lights are kept on a minimum, when it's dark out so they can sleep naturally at night.
Yeah, so definitely a lot of kind of systems modifications that we can think about to better help our patients sleep in the hospital. And final question is, I think in this case, this patient seems, very insightful. They're very motivated to, stick with their CPAP and motivated to get off of, sleep medications. Unfortunately, I think a lot of patients out there have some degree of resistance of, using non-pharmacologic issues, or maybe they feel the CPAP's uncomfortable. How would you recommend approaching management and counseling in these types of cases?
Yeah, you're always going to want to make the patient aware of the potential risks of, let's say pharmacological treatments or, the absentee use of CPAP, right? Cardiovascular overlay, etc. You want to avail them of alternatives that are reasonable, right? So if a person doesn't want to use CPAP, you might introduce the idea of oral appliances that can treat that from a dentist, let's say. Lifestyle changes, refraining from the use of alcohol, more exercise, and weight control are also alternative, treatments for sleep disordered breathing. And we are going to see patients with insomnia that make the decision not to proceed with, let's say, psychological treatments, which are obviously the first line preferred treatments. In that case, You just want to tailor your treatment to them such that you're offering most efficacy for most tolerability and lowest risk. So again, probably, let's say in 10 years time, what would that look like? It probably looks like a combination of dual orexin receptor antagonists and synthetic melatonin agonists.
That's really helpful. And I look forward to the day when these medications are more routinely available for all our patients. All right, I'm going to turn it over to Dr. Mack to talk about recognizing other sleep-wake disorders and advancements in sleep testing.
Great, thank you, Bernice. This next section talks about recognizing sleep-wake disorders and what might prompt sleep testing and further referrals for specialized care should you recognize these symptoms in a patient that's admitted, let's say, to the hospital. So first off, we're going to talk about parasomnias, which refers to complex nighttime behaviors that are physical, that occur when a person is asleep. Non-REM parasomnias occur due to incomplete dissociation between deep sleep and wakefulness. So you're essentially dealing with a person whose brain is partially awake and partially asleep. And this leads to common behaviors in young people, less so in adults. They include things like sleepwalking and sleep talking. In young folks, if you're a parent, you might have dealt with your child having night terrors. These usually do go away after the age of 12. More complex cases of these conditions that can confer safety factor issues, safety concerns would be something like sleep eating, sleep-related sexual activity, and sleep driving, as well as sleep cooking. Lots of different complex nighttime sleep behaviors can occur. I want to point out one specific entity, which is dream enactment behavior. When we dream, our bodies are usually paralyzed. We don't act out our dreams. For the patients that act out their dreams, that can be associated with the development of alpha-synucleinopathies, including Parkinson's disease, Lewy body dementia, and multiple system atrophy later on in life. So if you see complex nighttime sleep behaviors, that would be a point to refer on. Breathing-related sleep disorders are quite common. We recognize them in a sense that sufferers will endure symptoms of snoring, gasping at night, awakening due to gasping events, and bed partners or nursing staff might observe patients to stop breathing, aka observed apneas. If untreated, in the long term, they lead to cardiovascular problems such as high blood pressure, diabetes, heart attack, and stroke. Moreover, they cause excessive daytime sleepiness to possibly a dangerous degree, and they destabilize mood. We know that untreated sleep apnea is a risk factor for depression. And lastly, cognitive impairment. Since the discovery of the glymphatic system in 2013, there's a lot of work that has been looking into the relationship between untreated sleep-related breathing disorders and potential cognitive impairment later on in life, and that is something that remains to be investigated. You might see often in patients with delirium, as an example, have a mismatch between their sleep cycle and the light-dark cycle of the external environment. This can also occur in patients intrinsically. Basically, your internal body clock controls a number of bodily processes, including when you're most alert, when you're the strongest, when your cardiovascular status is most high. And there are certain bodily processes that make sense when it's light out, and other ones make more sense when it's dark out, and that's your circadian rhythm. Disorders of the circadian rhythm occur when you have a mismatch between your internal body clock and the light-dark cycle of the external environment. And I've illustrated on your screen on the right-hand side a variety of circadian rhythm disorders, the most common of which would be the delayed sleep phase disorder, where the person's internal body clock is naturally set later than the light-dark cycle of the external environment. These people sleep late and wake up late. 1 in 10 people with insomnia actually have this as the reason why they have problems falling asleep and staying asleep. The opposite of which would be advanced sleep phase disorder. These are people that sleep early and wake up early. We see this mostly in people who are 65 and above, the elderly folks, for the reason most of us actually have a physiologic advance in our sleep phase, meaning that we do sleep earlier and wake up earlier progressively as we get older. There are also other ones of note. You'll see irregular sleep-wake disorder there, where the person doesn't have a contiguous sleep period when it's dark out at night. They might have 3 or 4 or 5 sleep periods irregularly throughout the 24-hour period. We see this more in people with delirium, with dementia, and other neurodegenerative diseases, and sometimes in schizophrenia. When you see any of these kinds of conditions, these types of symptoms, please consider referral to a designated sleep center. And then other points to consider if you're dealing with depression that does not seem to respond to conventional therapy, it's treatment resistant, and the person also is comorbid snoring, obesity, or daytime sleepiness, that would be the time to refer on to rule out sleep-related breathing disorders. And of course, parasomnias, if the person has complex nighttime sleep behaviors, that can actually confer safety risks not only to the person themselves if they fall off the bed or and simply walk out the door, but also hurt bed partners and hospital roommates. And lastly, if you're dealing with a patient with insomnia disorder that is not responsive to cognitive behavioral therapy for insomnia or appropriate pharmacotherapy, there might be something underlying this condition, maybe some other sleep disorders contributing to the presentation. That would be also another time to refer on. How do we track, let's say, a person's sleep if you are suspicious that the person has some sort of underlying sleep disorder, if they appear to be exhibiting the signs of insomnia? You might do well to use validated questionnaires for serial assessment. That way you have something on paper and you can compare the patient's presentation from time period to time period. And here are the more commonly used ones. We have the Pittsburgh Sleep Quality Inventory, PSQI, Insomnia Severity Index, both of which are used significantly both in clinical and also research work. However, you'll see that the time interval assessed is not necessarily applicable to the inpatient milieu, the inpatient setting. The PSQI looks at changes in sleep over the past month. The ISI looks at changes over the last 2 weeks. So you might choose to use more hospital-adapted questionnaires, such as the Richards-Campbell Sleep Questionnaire, which focuses on sleep issues over one night. There's the St. Mary's Hospital Sleep Questionnaire, again, assessing 1 night's worth of sleep and night-to-night variability. There's also the Varon-Snyder-Halpern Sleep Scale, which focuses on sleep changes over the last 3 nights. And there is a more robust consensus sleep diary, which does take a bit more time to use. It reflects sleep status in the night and day previous. You're going to apply these questionnaires to your specific setting and the patient's needs. Now, there are 3 levels of objective sleep testing, some of which are deployed in the hospital environment. We have level 1 sleep testing, which is the classic polysomnography, meaning that you measure the brain waves, eye movements, chin movements, airflow, respiratory effort, oxygen saturation. You have a continuous ECG throughout the night, and usually there are EMG leads to the legs to rule out leg movements. And we have a very similar study in the level 2 sleep study. The difference between the level 2 and the level 1 sleep study is that the level 2 sleep studies are not attended by a sleep technician, whereas a level 1 sleep study means that the patient is observed by a sleep technician throughout the night. And lastly, we have home sleep apnea testing, which we term as level 3 sleep testing. And most of these tests look at respiratory airflow, some channels for respiratory effort, and a lead looking at your heart rate and oxygen saturation. So as you can see here, this is just a pictorial demonstration of what a technician-attended polysomnography setup looks like. We have the leads on your screen there. Well, let's take a look at what level 2 is. Well, it's the same thing, but now there is no technician. As you can imagine, level 1 sleep testing is the most strenuous and resource costing. Level 2 would be cheaper than level 1 testing to deploy. This is a typical polysomnography output. This would be the same output you see from level 1 to level 2 testing. You have EEG leads at the top, eye leads secondary after, respiratory effort leads, leads that measure airflow, your blood oxygen, and limb movements. And here's an example of level 3 home sleep apnea testing. Of course, level 2 sleep testing is cheaper than level 1 sleep testing, and level 3 is more affordable than the other two. And I'm just showing you a variety of different devices that are used to detect sleep apnea at home. I want to point out that home sleep apnea testing is exactly what it says it does. It only detects sleep apnea. The other forms of level 1 and level 2 sleep testing, they can also detect outside of sleep apnea, bruxism, limb movements that interrupt sleep, as well as EEG changes that allow us to rule out seizure activity, sleep staging, etc. And these home sleep apnea testing devices use a variety of technology, the newest of which uses peripheral arterial tonometry to detect apnea. In the future, we might be looking at more widespread deployment of actigraphy and consumer grade sleep trackers on the inpatient setting. Actigraphy is a research grade level device, and I've shown an example on your screen there. These are obviously even cheaper than level 3 sleep testing. However, actigraphy is validated for both clinical and research use on inpatient wards and ICU wards. Consumer grade trackers are following suit very quickly. There is developing evidence that demonstrates that consumer grade trackers are approaching the same level of accuracy as actigraphy, which is research based. And of course, as Dr. Jakob Green and the other Dr. Green mentioned, we will hope that we can deploy novel pharmacotherapies in the inpatient setting, reflecting the newest medications, the dual orexin receptor antagonists, of which they actually have emerging evidence that they can prevent the development of delirium. So the future appears bright to me. If you're looking for take-home resources to investigate and to know more about these sleep disorders that we've talked about here today, feel free to go to the American Academy of Sleep Medicine website under Clinical Resources tab, where you can learn lots about these and other sleep disorders that you might see in the inpatient CL setting. And with that, I'm going to turn it back to Dr. Green.
So that concludes our discussion today. We have a few takeaways for you. Number one, sleep is finely regulated by a complex network of circuits, including the VLPO, RAS, sleep homeostasis, circadian rhythm, and orexin, and is thus easily disrupted. Number two, treating insomnia involves a comprehensive 24 evaluation, biopsychosocial formulation, patient and treatment team education, addressing comorbidities, cognitive behavioral interventions, circadian regulation, and psychopharmacological considerations. In the hospital environment, the sleep restriction and stimulus control elements of CBTI can best be adapted. Pharmacologic choice should take into account current evidence, such as the AASM guidelines, symptom patterns, side effect profile, and comorbidities. And lastly, consider referral when presentation suggests the presence of another sleep-wake disorder, such as parasomnias, breathing-related sleep disorders, circadian rhythm disorders. And specialized assessment will likely involve 3 levels of sleep testing. We'd like to acknowledge 2 other contributors to this work. First is David Ross. He is a mentor of Dr. Yoel Green and Dr. Bernice Xiao's of ours, and he worked with us very closely in our publication of the paper on sleep-wake neurocircuitry. And second, Dr. Sarah Nash, with whom both Dr. Yao and I worked, who highly encouraged this presentation and provided mentorship and guidance along the way. And with that, thank you very much for attending. And here are our references. Thank you.